Welcome. My name is Ipsit Vahia. I'm a geriatric psychiatrist and the director of the Technology and Aging Lab at McLean Hospital and the Associate Chief of Geriatric Psychiatry also at McLean Hospital. I'm delighted to be here today with Dr. Husseini Manji. He's a visiting professor at Oxford University and at Duke University. Now, I first met Dr. Manji when I was a resident, so very early in my career, and a chance to have this conversation is a special honor for me, both professionally and personally. Dr. Manji sits at a very unusual intersection, having occupied leadership positions in academia, in the private sector, as well as the public sector. He's the former global therapeutics head for neuroscience at Janssen Research and Development, as well as the global head of science for the Science for Minds effort at Johnson & Johnson. Before joining Johnson & Johnson, he was at the National Institutes of Health and directed the Mood and Anxiety Disorders program there, the largest program of its kind in the world. So really, this is a rare and real opportunity for us to hear about mental health and the future of mental health from someone who has examined this issue from several different angles. Husseini, welcome.
Thank you, Ipsit, and thank you to Harvard Chan. Fantastic to be back here with many friends, and thank you especially to my good friend Dean Michelle Williams, and sincere thanks to all of you for what you do for human health. It's a real pleasure to be here.
Husseini, I understand that you're working closely with the UK government on a project designed to bring together the public, private, and academic sectors in what you've referred to as a Manhattan Project for the Mind, an all-out effort to tackle mental health and dementia particularly. Can you tell us a little bit more about this initiative, what it involves, and why this is the time to do it?
Sure. So I'm hoping that most of what I talk about today is actually going to be good news and a message of hope. But I'm going to start with some of the bad news. So I think some of the bad news probably most of you know, which are the grim statistics. So if we look at, things like neurodegenerative disorders, let's just take Alzheimer's disease, a devastating disorder that affects individuals, families, and society. Today, 100% incurable, 100% fatal, and every single person requires full-time care. And with our global aging populations, numbers are going to triple in the coming years. If you think about the serious mental illnesses, these by and large strike individuals when they're relatively young, often late adolescence, early 20s, and they're lifelong. So they've been called the chronic diseases of the young. And not only are they highly disabling, they basically are often fatal. So we know in many countries, if you have a serious mental illness, your lifespan is maybe 15 or 20 years less than someone without it. And a lot of that is from cardiovascular mortality, etc. But there's also the direct fatality with the tragedy we know of as suicide. So the last time I checked the statistics, there were only 3 forms of cancer which had a higher annual death rate than the death rate from suicide in the US. And globally, in young girls and women 15 to 19, suicide is the second leading cause of death. And mental illness affects everything. It affects your social functioning, it affects your occupational functioning, affects your scholastic functioning, it affects your physical health. You're much more likely to have type 2 diabetes, cardiovascular disease, osteoporosis. In our society, when you look at, say, a place like San Francisco, where you've got the dichotomy of the wealth of Silicon Valley and so many homeless people, and a large part of the homeless community are people with serious mental illness. And then when you look at our prison system, so many people who've been incarcerated have serious mental illness. So as I say, that's the bad news. I've depressed most of you already. But the good news is that I think there's reason for hope. And I think there's 2 big reasons for hope. One is we're making a lot of progress in the science, and one is because we're making a lot of progress in the culture of science, which I'll come back to. At the scientific level, we could spend 3 hours talking about the advances. So we've made advances in our genetic understanding, which is going to allow us to basically understand the pathways that could be involved. We're learning about epigenetics. So we know that almost all illnesses are a combination of genes and environment. And we've wondered, how does stress get under the skin? And epigenetics probably is one of the ways that explains it. We've learned about what we call plasticity pathways that regulates neuronal and synaptic function. That has led to the development of a novel antidepressant that works in hours rather than weeks. We've started to deconvolute our diagnostic classification, so the DSM classification, to recognize that there's actually subgroups of subdomains of illness. And what we've been able to do is map certain domains onto certain circuits and then target those circuits. So to give you one example, there's a domain related called anhedonia, which is the inability to experience pleasure. You lose drive and motivation. And we know a lot about the circuitry. So now we can target the circuitry and improve anhedonia. And in principle, you would improve anhedonia whether it's in a person who's depressed, bipolar, has schizophrenia, or drug abuse. We've learned a lot about the mind-body connection and a lot of reasons to believe that the physical health comorbidities are partly due to an overactivation of parts of the immune system. And in many patients, it looks like the immune system overactivation is even driving the mental health condition. So now we're targeting neuroimmune pathways. And then we may come back to this, but I think the digital technology revolution, which is changing a lot of aspects of healthcare, I think is particularly going to help mental health. So I think there's a lot of reasons to be excited about the science. I use the term the culture of science. What I mean by that is I think the light bulb has gone on that we can't do this alone. We're going to have progress if we work together. And I think some examples to think about, when HIV/AIDS first landed, it was a death sentence. And AIDS activists and others basically forced people to work together, pharmaceutical companies, academic researchers, governments. And in many parts of the world, now you can have a normal lifespan, more or less, and that only happened because people came together. More recently, with the COVID vaccines, obviously not perfect, but because people were willing to work together. So that's what this is about. So the people in the UK government contacted me a while ago and basically indicated that they thought they had many of the pieces there. What they wanted to do is bring their life sciences ecosystem, so for example, their NIH, together with their healthcare system. And many of you may know that they have basically universal healthcare. The National Health Service basically covers everyone. And they've got very good electronic medical records. And so in principle, you can do this so that the research actually reaches people, and you can also learn from people to drive the research. One good example recently with COVID, they did something called the recovery trial, which basically was trying to look at, for example, does dexamethasone work in helping with COVID? And within a few days, they were able to recruit tens of thousands of people by tapping into this National Health Service and the electronic medical records. In the US, we struggle with 30 people here and 20 people there, etc. So in principle, it's a good way to work. So what we did is we had these 10 Downing Street roundtables where we brought people together, academics, government. We were able to bring many industry partners to the table, certainly pharmaceutical companies, but I was delighted that major digital and data sciences companies like Microsoft, Apple, and Verily are all at the table because they want to see how they can help. And so hopefully fairly soon, and I've been involved in a couple of these. One is the neurodegeneration mission and one is the mental health mission. And with the mental health mission, what we're going to try and do is form these networks where we can do research, but the networks are going to be based, some of them would be based at the equivalents of the Harvards of the world, the Oxford and Cambridge, but a lot of them are actually going to be based where you have underrepresented minority, socioeconomic difficulties, so Birmingham, Nottingham, Liverpool, Manchester, because as I said, we want the research to be bi-directional. We want to do the translational research and roll it out, but then we want to learn from people. It's not going to be a one-size-fits-all. If you happen to have, poverty, if you've had early life stress, unfortunately we know physical and sexual abuse is very common, etc. Does it determine what you respond to, what symptoms, etc.? So hopefully these will get launched soon. I was mentioning to Michelle, they were supposed to have gotten launched in July, and then a week before they were supposed to get launched, Boris Johnson resigned, and then they appointed another prime minister who lasted 4 weeks, and now on their third one, but to the best of my knowledge, very soon they're going to get launched. And although it's going to start in the UK, I've had discussions with NIH directors who really want to form ties, and partly given the UK's ethnic and racial diversity, we think, and again, Michelle and I were talking about the Wellcome Trust is doing a lot in different parts of the world. We think a lot of findings will be applicable elsewhere. It's not like you're going to take what works in Liverpool and it's going to work in Rwanda. There'll obviously have to be nuances. But so I'm optimistic. It's going to be a lot of work, but hopefully it can really make a difference.
Sounds really exciting, and there's a compelling case that you make for why the science is where we need it to be to sort of make that next leap of progress. But we've learned that you need political will to really push the science into true impact. Yeah. Can you tell us a little bit about what it takes to generate that political will? And I think to tag on to that, I think our listeners would be curious to know what are the obstacles that you've run into and had to overcome with an undertaking of this magnitude.
Okay, so I think that the question about political will is very real. You know, you can have the greatest ideas in the world. To make them happen, you need the political will behind it. And I think, you know, to me, it's a travesty when you think of, you know, the mental illnesses, how much they affect. And Tom Insel, former director of the NIMH, had even had an editorial. You know, there's a paper that was talking about how many of our patients are unfortunately incarcerated. And there's overwhelming data that someone with a mental illness who's incarcerated costs much more than someone without a mental illness. And so his article was titled, you know, we're spending a lot of money but on all the wrong places. You know, similarly with homelessness, similarly with workplace productivity, etc. There ought to be a way, if we're spending all this money, can we not think of a way? We know that there's a housing budget and a judicial system budget and there's this healthcare budget, etc. Can there not be a way where we can say, look, by treating the underlying cause, we'll actually have a cost saving? So you need to galvanize the people. That's one of the reasons it's a little bit easier in the UK where the system's a little bit connected. In the US, I think we're going to try very hard to break down these silos to really show that not only will you impact people in a positive way, you'll help people. One of the endeavors I've been doing is we think that cities are a place where a lot of this comes together. So can you work with cities, you know, for example, like New York City, and talk about, look, you've got a homeless problem, you've got this crime problem, you've got a school problem, you're spending money anyway. Let's consider using it to help with mental illness. So that's one of the things. The other thing that I think, again, this will be, you know, common sense to all of us, is that while mental illnesses do often have a biologic basis, it's not about treating a molecule in a cell. These are people with lives who function with their families and society. So we've known forever that a holistic approach gives you better outcomes. You know, there's data from some countries around the world that conditions like schizophrenia have a better outcome because of more family involvement. I undertook a pilot in a place of Germany called Lower Saxony, where we tried to show that if you combine medications with services, and these weren't high-tech services, these are outpatient services, you know, psychotherapy, etc., we had a 50% reduction in inpatient hospitalization. You know, more and more in healthcare you hear that sort of the buzzwords, real-world evidence and value-based cares. I can't think of a better example than mental health. You know, as I mentioned, if you're affecting social, occupational, scholastic functioning, you know, what more real-world evidence do you need than if a treatment does that? If treatment keeps people out of jails, people live independently, that's there. And then if we roll these services together, and you can reduce hospitalization by 50% and give people outcomes, isn't that what value-based care is? I mean, here's and I hope there's no surgeons in the room, and I have nothing against surgeons, but here's how the system is broken today. If you went for a joint replacement the surgeon would get paid. And if the joint replacement didn't work and you'd come back to get it done again, they'd get paid again. There's something wrong with that situation. We've got to move to value-based outcome and pay people for performance. So one of my good friends, Tom Ensel, he's trying to do something. He's launching a new company called Vana Health, which is again taking this approach. Look, we can get people better. Yes, many will need medications, but then they need services. There's got to be a way for society to be able to reward that. So I think that's one of the things about, what you mentioned about political will as well. I think actually yesterday President Biden in his State of the Union address even mentioned parity for mental health. I think that's one of the other travesties. And again, another good friend, former Congressman Patrick Kennedy, he's been fighting to get legislation. And although the legislations are on the book, insurance companies ignore them with impunity. It's unfair for someone with a mental illness to be treated differently for someone with a physical illness. And you might have great insurance that covers your physical illness, but if you've got a mental illness, sorry, we're not going to cover it. That's another thing we got to change. And then the third big thing about the political will, I think, is we need more research funding. And I am amazed at the progress in an area like oncology, where we've gone to so much more personalized treatment. You can measure what's going on. We've got things like immuno-oncology. We've got CAR T-cell therapy. So, more power to them. But it's happened because President Nixon launched the war on cancer something like 70 years ago. There's been sustained investment, and now it's paying off. And I know my oncologist friends don't like it when I tell them how much more complex the brain is, but it is. It is more complex, and we've had a fraction of the funding, so we need more funding. One of the things that happened in the UK is about 8 years ago, former Prime Minister David Cameron, when the UK was the head of the G8, it was called the G8 then, it's called the G7 now, he hosted a summit on dementia that I was privileged to attend. And it's actually had a lot of benefits. So the research funding for dementia, NIH's budget has quadrupled, Canada, UK, France, etc. One of the other things that came out of it was we were able to launch a dementia fund. So we got people to put in money for innovative dementia research. Bill Gates has joined it, and it's now at $350 million. So I'm trying to, generate a similar mental health fund. And the idea would be get people to put in money, of course, governments, but there's more philanthropic money going in. One other idea is about issuing bonds. So during wartime, we had issued bonds, and the idea is, could you issue these bonds which have, this fairly long lifespan because research is slow, and show people that, for example, the state of California issued these bonds around stem cell research, and it's paid off amazingly. So it's paid off amazingly with respect to the number of biotech stem cells companies that are now being formed there, and they're adding to economic prosperity. And there's something like, 100 trials, clinical trials of stem cell drugs. So we need things like that. And you guys are in one of the hotbeds, San Francisco and Boston, Cambridge is one of the hotbeds where the amount of economic prosperity you've seen, because this is a science and innovation hub. So that's one of the other things. So to get back to your question, it's not easy. You need to herd cats, but I think the time is right. Partly with COVID, mental health is on everyone's radar screen. Even CEOs have told me that one of the big things they're talking about is their employees' mental health, because you'd hope most of them care about the employees, but they also care about the bottom line. And from absenteeism and something called presenteeism, where you're there but your neurons aren't firing, it's costing companies a lot. And young people care a lot about mental health. I even saw a survey which asked young people, what are the factors that would help you determine which company you worked for? And a company that paid attention to mental health was one of the highest factors. So it's a competitive advantage. So I think some of these things are aligning where we can sort of try and work together to force these changes. I'm under no illusions. A lot of it is going to be 5 steps forward, 4 steps back, beating our heads against the wall, etc. But the unmet need is so huge that let's try and do it. Okay.
Thank you, Hussaini. I do want to just take a moment to repeat one of the points you made, which I thought was so elegant and gets to the heart of the issue, which is mental health care is not about targeting cells with molecules. It's about treating real people with lives and families. And I think we would all do well to really have that line imprinted in the mental health care work that we're focusing on. To get back to your point, though, about progress and this being resource-intensive, difficult work, I don't think there's any questions about the need. There might even be some wind in the sails around this. But how do you see this effort translating to parts of the world that are less resource-intensive than the US or the UK? India and China, for example, are going to have the raw numbers of people with mental health care needs. How do we translate this progress so that everyone can benefit from it?
Yeah, obviously a huge problem. It's one of the reasons I admire Michelle and what you're doing at Harvard School of Public Health, and it's something we've got to take on as a common challenge. I don't think there's easy answers, but I'll give you what I think are hopefully two sides of the equation. Now, in terms of, there's definitely some bad actors in the pharmaceutical industry, the pharma bro, Scarelli, you look at the insulin prices, which are going sky high, etc. We got to, rein that in. We shouldn't allow it. There is the other thing, though. Almost every analysis shows that medications are actually very cost effective, so that medications reduce hospitalization, allow people to go back to work, etc. So I can't remember what's a fivefold, return on investment, etc. In the US, our healthcare costs are astronomical, but when you look at the medication cost, it's a small part of the overall healthcare cost. Most of us, if you have insurance, you really from when you go to a hospital for a procedure, you really don't think that much about it. But if you actually look at the bill, it's staggering, $2,000 for this, $5,000, you don't end up paying, but that's one of the things, so we've got to rein some of those things in. But I think we've got to do something about medication costs as well, and that was something else President Biden talked about. One of the problems is that it's very expensive and takes very long to develop medications. And so, it's not uncommon for it to take 10 to 15 years, cost over $1 billion drugs, and 90+% of things actually fail. And, I'm obviously in neuroscience, so I, just last year until last year, I looked up the Alzheimer's data. It was something like 98.5% had failed, and at the cost of billions of dollars, because they fail late. And what I mean by that is if it's an antiviral, if it doesn't kill the virus, you stop, you don't go on. Here you take hundreds of people with declining cognition, you put them on the drug, you follow them for years, and then see if it separates from placebo, which has cost you hundreds of millions, and that's when it fails. So that's why, with most things you buy, in principle, there's the cost of what it cost, and then you add a markup. In pharmaceuticals, unfortunately, because you've got to kind of pay for the failures, that's not the case, right? You've got, you've spent X amount, you've got to recoup your investment, not only on this drug, but all the things that led to it. And that's one of the reasons why, most of you may know that many large pharma companies have left neuroscience, almost all have left mental health. I was delighted that I was able to, keep J&J in it and grow it. They've left for two big reasons. One is it's fair to say we just don't know as much about what's going on in the brain as you do, for example, in immunology, or if you could do a tumor biopsy and see what's going on. So it's much higher risk. But then the second reason is what I was talking about, even in terms of parity for mental health. Even if you're allowed to invest in medication and you get it approved, you're not going to get it reimbursed necessarily. Insurance is not going to pay for it, etc. And I'll give you a personal example. So I helped develop Spravato as ketamine, and the feedback from patients and physicians is fantastic. And of course, not everyone responds, but people who respond do well. Because it causes some dissociation and some blood pressure effect, I basically made the decision, you don't go home with it. You go to a clinic setting, you get it, you stay there for 45 minutes, then you go home. So that means that the clinic has to have some healthcare support staff there, and insurance won't pay for that. And I'm thinking, this person has tried 5 medications, they've tried ECT, they've been in and out of hospital. You're not going to pay 45 minutes for a physician assistant time? So that's been one of the problems. But coming back to your question, and this is something Michelle and I were just talking about, we've also got to be very creative about how we can get these medications to other parts of the world. So to give you one example, again, while I was at J&J, we were fairly confident we had discovered a brand new drug for multi-drug resistant TB. Now, multi-drug resistant TB is almost exclusively a problem in Africa, especially South Africa. So it would be very tough to convince the CEO to spend $1 billion developing this drug where you're going to make $500. I'm inventing, but it's just the business case isn't there. So we worked with the Gates Foundation and we said, look, we'll provide the drug, we'll provide you all the expertise, we'll provide you all the expertise about the clinical trial and the manufacturing. Can you help us fund the drug? And they said yes, and the drug was approved, and now it's helping a lot of people. So that's one of the creative things. One of the other sort of creative models I've embarked on, and it's with also talking to some Ginger Fellows, which I think is a great program. So one of the problems is that you have to get, it's completely understandable. You need to do trials of the drug most of the time in the country you're going to get it approved. And so obviously we do with the US, with the Western Europe, etc. Now you almost certainly cannot do it in each African country one by one, because you're probably going to be losing money on the price of the medication. So we decided to launch this initiative on schizophrenia in Rwanda. And we spoke to some of the other East African countries, Kenya, Uganda, Tanzania, and said, look, we're not asking for a stamp of approval, but if the Rwanda data is very good, would you be willing to look at it to potentially consider approving it in your country? Because I was just honest with them, the company is not going to do one by one. So that's one of the models we've undertaken. One of the other things that I think is a big thing is also try and think about the medications that might be the most fit for purpose in resource-challenged areas. And one of the things I was really proud that I was able to develop, so many of you may know with schizophrenia, terrible disease, the single biggest factor underlying relapse is not being on medication. And most of the time people stop their medication, they relapse, they're hospitalized, they're incarcerated, they're homeless, etc. And some people have, dozens of relapses. So we spent a lot of time coming up with long-acting treatments. So can you get an injection once in a while, and you don't even think about the medication, and it's your system for X amount of time. So we developed a once a month, once a 3 month, and then I was amazed we were able to develop a once every 6 month, which is almost as frequent as you get the COVID vaccine, so it's almost vaccine-like. And when you're on the medication, 95% of people don't relapse, and then even when you stop the medication, it takes a long time before you relapse, so that you sort of maintain stability. So even if you lost to follow-up, we did a study not with the once every 6 month, but with a shorter acting one, once a month and once 3 months, in an incarcerated population. And you can imagine how much I had to convince people to do the study in an incarcerated population, but it was people with schizophrenia who had been incarcerated. And I basically make the argument that, if your illness isn't treated well enough, if you're having hallucinations and delusions, there's a very high likelihood that you're going to get into trouble with the criminal justice system. We would like to show that if you treat the condition well, the rates of reincarceration are lower. So one group was randomized to treatment as usual, and one group was randomized to the long-acting, and the evidence was clear. The rates of reincarceration were much lower if you were on the long-acting treatment. So this long-acting treatment, that sort of thing, where it's a resource-poor area, I think one of the other examples. One of the other examples, I think, is vaccines, and I'll give you 2 examples. So again, my former boss at J&J, his name's Paul Stoffel. He's a great guy. I just think a world of him. When COVID hit, he really wanted to take the global picture in mind. So he was thinking, what are we going to do in parts of the world where you don't have -40 or -70 freezers that you can get the drug to this village, etc. You're not going to have the ability to bring people back regularly. So he decided to try and develop a one-shot injection that could be stored at room temperature. And it worked. Now, the problem is it caused slightly more clotting than the mRNA vaccines, and that's just something you learn, so it hasn't taken off as well. But the whole idea behind it was we recognized that, Moderna and Pfizer vaccines would probably be very good for the Western world, but in parts of Africa and other places, this might work. So it actually ended up not working. But the other area which might work, and we might talk about this, is Alzheimer's might be on the verge of finally coming up with some treatments. And again, it's not going to be practical for people in many parts of the world to go to an infusion center once a month for an expensive monoclonal antibody. Vaccine is a different matter altogether. And so we're trying to help some people really think about the vaccine strategy, initially to treat. So if you've got early dementia, you can show that with the vaccine you slow it down. But then if the vaccine doesn't have a lot of side effects, you can move even earlier and hopefully prevent the dementia, because I'm one of the people who thinks that Alzheimer's disease is not dementia. The dementia is the end stage of a disease process that's been cooking in your brain for maybe 20 years. So if you wait until people have dementia, it's pretty late. But if you can identify people early on, then you can prevent the ravages of the illness. Okay?
Let's talk a little bit more about dementia,
Okay.
Hosseini. As a geriatric psychiatrist, obviously I am biased because this is my daily life. But a lot of the treatments for dementia or the recently approved drugs and some of the controversies that accompanied them have been in the news lately.
Yeah.
Dementia is one of the big neuropsychiatric public health issues of our time, arguably the neuropsychiatric public health issue of our time. What is your sort of assessment of the state of the science around developing new treatments around dementia and Alzheimer's disease? You alluded to vaccines,
Yeah.
but how do you see this field
Yeah.
evolving over the next few
Yeah.
years?
And I'll have to say that, when you're a researcher, you almost have to be optimistic, otherwise you'd give up, right? so but I am actually quite optimistic. So I think we're actually on the verge. So, we had failure after failure after failure. And we were actually, the field was getting a lot of criticism. Why are these idiots throwing good money after bad? They're stuck on this amyloid hypothesis, etc. But lately, I think the data suggests that we might have actually turned the corner. So aducanumab, Aduhelm, was the one that caused controversy, and that was a Biogen drug that was complicated. They initially did the trial. It looked like it was not going to work, so they stopped it. They reanalyzed the data and said, no, it might actually be working. They had one study which was positive, and one which wasn't positive. It went to the FDA, when there's these big decisions to make, the FDA often calls an advisory committee. I think most people, including myself, thought that the FDA would ask them to do another study. That you've got one positive, one, they do another study. And, I really do feel bad for the FDA because they're in a tough spot. If it's your mother who is, desperate need, study's going to take 5 years, she's willing to take the risk. So I think they sort of bowed to the pressure that, okay, let's approve it and gather the data afterwards, even though the scientific data was like that. As you said, it's one of the biggest areas of unmet need. If it's any of our relatives, right, we'd want them to have it, not wait 5 years. But then I think they also had a misstep in terms of how much they charged. The newer one called lecanemab, it's an Eisai drug combined with Biogen, also targeting some of the amyloid molecules. highly statistically significant. So it clearly is having an effect. The amount of effect, so the statistical significance basically tells you, is the drug and placebo separating? The amount they're separating is not this. It's more like this. And that's a question. So I think most of us think that, if it was our relative, even though it's not this effect, we'd want them to have, 9 months or more of independent living. And there's a good chance that even with this effect, if you start earlier, you'll see a bigger effect. And the history of most medications is that the very first one is not the magic bullet. You sort of get this effect, and you build on it, and you build on it. So I think it may well be the first approved, right now they've got accelerated approval. They'll, I think likely get full approval. That'll be the first one that'll hopefully be accepted, etc. They also have very low rates of the side effect called ARIA, or something called vasogenic edema. Our thinking is that you have these amyloid plaques in the brain, but you also have amyloid plaques inside blood vessels. And when you pull the amyloid out of the blood vessels, you make the blood vessels a little leaky. And on MRI scans, you can see this thing called ARIA, or vasogenic edema. In most cases, it's asymptomatic and it reverses. In some cases, it's not. But fortunately with the lecanemab, so far it looks like it's quite rare. So side effect wise, it doesn't look it's too bad. You shouldn't go on certain blood thinners, etc. And then Eli Lilly had very good phase 2 data, both on biomarkers and on some cognition. And sometime this year, they will release their phase 3 data. And if it holds up, that might be another one. And as I said, I think it'll be the start. There is a lot of research, so the Alzheimer's community, I think has been a very good community to come together. So they've been doing a lot of genetic studies together, these things called genome-wide association studies, and a lot of novel targets have come up, a lot of them actually in the neuroimmune system. So now there's a lot of drugs targeting the neuroimmune system, and one that I think is almost certainly going to play a role is this molecule called tau. So I think it's quite likely in the future we'll be better able to identify, do you have Alzheimer's that is more amyloid-driven or tau-driven or neurodegeneration? Do we need combination? But that brings me to the other, what I think has been a remarkable achievement, and that's in the field of biomarkers. So, as I said, the overwhelming evidence suggests that the disease is cooking in your brain, long before you get dementia. So obviously you need to identify people early. Until relatively recently, you had to go to MGH and send someone for an amyloid PET scan, etc., which, you can't, we talked about how common this is. You can't take every 60-year-old off the street and send them for a PET scan. So people start to think, could there be another way to do a screen that doesn't have to be perfect, but it says, Mr. Smith, you look fine, come back next year. Oh, Mr. Smith, this looks a little abnormal, let's send you for the PET scan. And two big areas people were doing were retinal imaging, so you can pick up amyloid in the retina. And so the idea was that, a lot of people 60 years and older do go for an annual eye exam. Could they get the retinal amyloid scan done? And then plasma biomarkers. And I was one of the people, I'll admit it openly, I thought that plasma biomarkers might be a good screen. Well, it's not going to replace imaging. I might have to eat my words. The plasma biomarkers are looking that good. One of the recent staging of Alzheimer's has been sort of this ATN staging for amyloid, tau, neurodegeneration. It's looking like these plasma biomarkers might even be able to pick that up. So if we can do that, then I think, if you have treatments, and you have the ability to identify people early, that'll be fantastic. And one of the things is if you can show that a monoclonal antibody works, then in principle you can make, so the monoclonal antibody, you're basically giving someone an antibody. With the vaccine, you're asking them to make the antibody. But once you know which part of the antibody works, in principle, you should be able to make a vaccine that tells your body to make the same antibody. So that's a reason to be optimistic. The other thing I'll mention, and many of you may be familiar, is that a lot of these diseases are genes and environment. And over the last few years, there have been Lancet publications, etc., which has been identifying that maybe something like 50% of the risk could be due to modifiable risk factors. Now, not easy to modify, but modifiable. And roughly speaking, what's good for your heart is good for your brain. So cardiovascular, type 2 diabetes, social isolation is bad, depression is a bad one. Having depression puts you at increased risk, hearing loss, etc. One of the things my group was also doing is, we're better at trying to watch our blood pressure or trying to watch our cholesterol, etc., because we can measure it. You can see, what's my blood pressure, I got to do something. So we've basically come up with what we're calling a brain health score. It's not that fancy, and we wouldn't compare your brain health score with mine, but we'd compare mine over time, see what my score is, and then see if mine is going downhill, and at the same time tracking what's my diet, exercise, sleep, etc. like, and then sort of send people a reminder, look, it could be your sleep deprivation that's causing this, it could be this. And the hope is if we can give people a number, they can start to focus on it like some other things. So as coming back to your question, I'm cautiously optimistic. In this field, as I said, in this field, 90% of things fail. So a lot of there will be failures. There's no doubt things will fail. But I think we're turning the corner where we'll have successes as well.
That's really inspiring to hear, especially because we've been hungering for a true breakthrough in this space.
Yeah.
I think in the 7 or so minutes we have left, Hussaini, let's kind of come back to something you alluded to earlier and have referred to in terms of data and technology.
Okay.
And I think the theme that's very much also in the news lately is that the AI wave that was impending may actually already be here.
Yeah.
So can you spend some time talking to us about what you see as sort of where AI fits into the future of mental health care, and what we should be worried about? Because
I think very good question. So as you said, alluded to earlier, so I think technology is actually going to help a lot. But, and I'll come back to the but. So, the way technology could help. So right now, for example, the way we diagnose depression is you go into your doctor's office and say, what's your mood been like? How have you been sleeping? How have you been eating? How have you been this? And there's a lot of data to suggest that, when you go into that office and what you're telling them, they're asking you, how have you been doing over the last 4 weeks? Most of what you're telling them is probably what you remember the last couple of days. And it's relatively subjective. So now there's digital ways to pick this up. And the idea would be that when you go to the doctor's office, there's a readout in front of them that basically tells them all these things. And for me, the digital tech isn't to replace healthcare providers, it's to help them. I think you always need a healthcare provider. But if you can arm them, then we know how busy people are. They're not spending 15 minutes saying, how did you sleep? How did you eat? That's in front of them. They can focus on you and your life. The other thing, most of these psychiatric illnesses have multiple recurrences and relapses. And today, unfortunately, you wait until someone relapses, they end up in the emergency room, they make a suicidal attempt, they end up, there. Wouldn't it be fantastic if you could pick up an early warning signal? And we have done work, and I think John Torres from Harvard just had a paper recently suggesting that using some of these sensors and smartphones, interestingly, speech is turning out to be powerful, sleep, motoric activity. You can start to get early warning signals that someone could be on their way. Now, you don't just automatically act on it, because maybe they didn't sleep because they had a toothache, not because they're manic, so you got to validate that. But the idea would be that if you can use this, if you could get early warning signals, could you help the person long before they need hospitalization? So I think that's one of the other benefits. One of the benefits is that we know there's certain kinds of psychotherapies that work, but we have a shortage of trained people to deliver it. So could you also use digital technology supported by a person to deliver it more broadly, and you don't have to be close to Harvard to do it. So those are some of the things I think that are positives. Same with the data. If we can really interrogate large amounts of data, we'll really be able to figure out subtypes of people. Are you more likely to respond to this? Do you have this? Do you have this? Etc. And so I think that's positive. The watch-outs, one is, I would say, privacy of the data. and data ownership. So the privacy is a big one. We're hearing a lot in the news. Companies are selling information about people. This is particularly sensitive information. We've absolutely got to make sure it does not get misused. So that's one. Data ownership. So my thinking is that you should own your own data. You own your own data, and you decide who can share it. So when you're well, you might tell me, if I'm starting to get depressed, you can tell my sibling or you can tell my doctor, and that's all we would do. But it's your decision and your data. So that's one of the things. The other thing I think we've got to be careful about is, in general, we think this technology is going to democratize things, make things better. But there is a possibility of not 100%. So one thing is in this things called algorithmic biases. And some of you may have read, during COVID, as oxygen saturation was one of the things you measured. And then people actually did studies to show that if you're a dark-skinned person, the pulse oximeter actually gives you a different reading, because it's probably been tested mainly on white people, etc. So they hadn't taken that into account. In terms of mental health, almost all the research studies are done in high-powered places like Harvard. So your catchment area is usually a specific demographic. You don't have the ethnic, racial, socioeconomic diversity, and there's data to suggest that if you're an African American versus a Caucasian, if you show up in the emergency room with the same symptoms, if you're Caucasian, you're more likely to be called bipolar. If you're African American, you're more likely to be called schizophrenia. So you want these algorithms to be as accurate as possible and take in the diversity, because otherwise we're going to make decisions, based on, false information. So I think, as I said, I think these technologies can help. I think, in my opinion, so one other thing I'll mention, most of the time we think of regulation as bad. I think it's good, because what you have, if you go and look at how many apps there are, there's hundreds of apps which claim to help you relax with mindfulness, with this, with that, cure world hunger, do this. They're just, just things that are put out there. And, mindfulness or meditation or helping you sleep or exercise, it's good for all of us. But that's different from treating serious illness or making a decision. So I would actually like these things to be regulated. So someone says, yeah, okay, you've actually proven that this does what you're saying it does, and so it's not used willy-nilly. And then what's, certainly in the news, you can't open everything without hearing about ChatGPT, right? So I think that's where we have to be a little bit careful. So, I'm not an expert. My understanding is it's similar to IBM Watson in that it's analyzing a ton of text data and then providing answers. And IBM Watson is providing simple answers. ChatGPT is much more sort of language, prose, etc., and sounds more convincing. But two things. One is a lot of the medical information isn't text. So, for example, X-ray images and stuff. You're going to be making a decision based on things that's not text. And then there's been actually some data asking him about quality control. Some things haven't worked out. So I think you've got to be very careful. And one company got into trouble when they were using it in chat bots to help people with counseling. And, so we've got to be very careful. I'm a strong proponent. I'm a strong believer these things will help. But like many things, if you just, do the Wild West, you can hurt things. And when you're talking about people's health, you got to be very careful. Okay.
Well, Saini, thank you. I think we could talk all day about some of the things that you've touched upon, but you've kind of given us an inspiring message, one of hope, but that even though we may see some glimmers in the distance, the path to them is long, and there are pitfalls. And I think even as we do the work and we use the tools that science is giving us, there are things to be conscious of. Equity is a big one. Privacy, you alluded to. And biases of various forms with technology. We will wrap up our conversation here, but I want to thank you on behalf of our audience in the studio as well as those watching us online. For those that are in the studio in person, I'd like to invite you to join us for a reception if your schedules allow. This reception will take place in just a few minutes on the first floor in the Kresge Room 110 from 2 to 3 p.m. and I hope you can join us. Have a great afternoon, and I hope you will join us again soon in the studio.
Thank you very much.